In the shadowed corridors of Victorian medicine, women's bodies became both battleground and mystery. Whispers of wandering wombs, nervous afflictions, and secret therapies circulated behind closed doors, blending science, superstition, and societal control. From the hands of doctors to the ritualized baths of spas, intimate treatments promised relief while concealing deeper truths no one dared name. Pleasure, power, and paranoia collided in ways that shaped lives, histories, and even technology, all under the guise of health. This is a journey into that hidden world, a place where fear masqueraded as science, authority dictated morality, and what was left unspoken often revealed more than words ever could. Step carefully, for behind every prescription and procedure lies a story of secrecy, paradox, and the uncanny intersections of human desire and medical knowledge. In 1859, a fog-choked London street gave way to the polished brass and dark oak of Dr. Percival Whitmore's clinic. Gas lamps cast trembling shadows on the ornate wallpaper, and the faint scent of lavender and disinfectant mingled with something far less medicinal, the quiet hum of suppressed desire. The waiting room was deceptively calm. Polished wooden benches held women of every social standing society, matrons with corsets biting into pale flesh, governesses with weary eyes, and young wives clutching handkerchiefs embroidered with anxious precision. Each woman carried the invisible weight of nervousness, irritability, insomnia, or a general sense of unease, the euphemistic symptoms that Victorian physicians collectively labeled hysteria. The room's silence was punctuated only by the soft scratch of a ledger, the occasional cough, and the distant ticking of a mahogany clock that seemed to mock the anxious hearts of its occupants. A nurse, prim and perfectly gloved, moved quietly between chairs, offering cups of weak tea and polite inquiries. Yet behind the decorum, an unspoken understanding permeated the air. Each woman knew why she had come, though she might never have dared to speak it aloud. Hysteria, the diagnosis that covered everything from irritability to sexual frustration, was considered both medical and moral. A nervous wife who admitted to restlessness risked whispers of impropriety. A servant girl who complained of fainting spells risked punishment or dismissal. In Victorian London, female desire was a crime against propriety, and yet it thrived invisibly beneath the skirts and petticoats of every woman waiting. In a corner, a mother of three clutched her daughter's hand with a grip that was both protective and trembling with her own guilt. The girl had been restless at night, her cheeks flushed, hands fidgeting, a perfect case of what doctors might later describe as nervous excitement. The mother had avoided scandal by seeking medical counsel, hoping that a learned physician could restore order to her child's delicate constitution. Elsewhere, a widow, her black dress trimmed with crepe, traced the intricate carvings of the armrest with a polished fingernail, pretending to focus on the floral patterns, while her mind wandered over sensations she had never been taught to name. These women were bound by silence, and yet by necessity, bound to confessions that would be recorded in meticulous detail, yet misinterpreted, misunderstood, and transformed into clinical reports that disguised the very pleasure they were about to experience. The air in the room was thick with anxiety and anticipation. Newspapers lay scattered on small tables, their front pages filled with reports of cholera outbreaks and railway accidents, yet no mention of the invisible epidemic that gripped every household: nervous disorders, fainting spells, and the ineffable restlessness that doctors termed hysteria. Etiquette demanded patience, but behind the polite nods and stiff conversation, each woman was calculating. How long would her treatment take? Would she emerge embarrassed or relieved? Would her condition be deemed severe enough to warrant prolonged attention, or trivial enough to be dismissed with a brisk admonition? And all the while, the clock ticked on, measuring the passage of quiet suffering in this sanitized theater of female nerves. A faint cough heralded the arrival of Dr. Whitmore himself. He moved with deliberate grace, his top hat in hand, spectacles balanced on the bridge of his nose. To an outsider, he appeared as any respected Victorian physician, stern yet courteous, learned yet approachable. But the women waiting knew that behind the clinical veneer lay the most intimate of procedures. They had come for relief, though relief was a word neither they nor their doctor could articulate. Hysteria was not a scandal to be whispered in public, nor was it a shameful indulgence to be admitted outright. It was a medical necessity, a path to restoration that required trust, discretion, and compliance, with a set of instructions both arcane and intimate. As the first patient was called, the waiting room seemed to exhale collectively. The woman rose with a mixture of dread and anticipation, her gloved hands trembling slightly, her lips pressed into a tight, polite line. One by one, each patient would face the physician, each session a secret ritual designed to soothe nerves, restore composure, and cure what could not be named. Outside, London carried on fog rolling along cobblestones, horse-drawn carriages rattling over stone, the River Thames swallowing another gray twilight. But within Dr. Whitmore's clinic, time slowed. Here, in this darkened sanctuary of polite secrecy, the invisible currents of female desire would meet the clinical hands of Victorian medicine, and what passed for treatment would forever remain one of the era's most bizarre, misunderstood, and profoundly human mysteries. By the mid-19th century, hysteria had earned its reputation as the ultimate catch-all diagnosis for women. Nervousness, hysteria. Insomnia, hysteria. Irritability, fainting, melancholy, restlessness, sexual desire, any symptom, no matter how mundane or extreme, could be bundled under this single terrifying label. The term itself, derived from the Greek hystera, meaning uterus, carried a centuries-old myth. A woman's womb could wander through her body, pressing on organs, tangling nerves, and sending her sanity spiraling. Plato had called it an animal within an animal, desperate to bear children, and for centuries, this metaphor shaped every understanding of female physiology. By Victorian times, the wandering womb theory had been abandoned, but the hysteria diagnosis endured, cloaked in scientific authority, yet rooted in cultural fear. Doctors believed women were inherently delicate, fragile, and susceptible to reproductive fluctuations. Victorian medicine painted female bodies as governed entirely by reproductive function, which dictated temperament, intellect, and morality. If a woman exhibited restlessness, it wasn't just a sign of strain, it was a physiological crisis, a warning that her uterus was misbehaving. One physician wrote that hysteria could manifest as fainting, palpitations, muscular spasms, nervous excitement, and a tendency to irritability, a list so broad it might include nearly every complaint a woman could have. Thomas Sydenham, an English physician, estimated hysteria as the most common disease after fever, affecting roughly a quarter of all women, a staggering proportion that fueled the medical obsession with treatment. Hysteria's symptoms were as diverse as its sufferers. Some women experienced headaches or dizziness, others suffered shortness of breath, irregular menstruation, or digestive complaints. Yet no physical test could confirm the diagnosis. Instead, it relied entirely on observation, interpretation, and crucially the cultural lens through which doctors viewed female behavior. A young woman who laughed too loudly, spoke her mind, or displayed sexual curiosity could find herself labeled hysterical, her behavior pathologized rather than understood. It was less a medical condition than a social tool, enforcing conformity under the guise of science. If a woman is restless, she is unwell. If she is unwell, she must be treated, wrote one contemporary physician, summarizing a system designed to control female bodies and minds. Treatment methods reflected the era's profound ignorance of female sexuality. Doctors prescribed everything from dietary adjustments and herbal tonics to hydrotherapy, rest cures, and, most famously, pelvic massage. These treatments were clinical in tone, but intimate in execution. The rationale was simple. If hysteria was caused by a misbehaving uterus or suppressed sexual tension, relieving the body of its nervous excitement would restore balance. Textbooks detailed the procedure with care. Oils applied, hands moving in circular motions, pressure maintained until the patient exhibited sudden muscular contractions and flushed skin. What Victorian doctors called hysterical paroxysm was, in fact, orgasm. Yet the physicians remained oblivious to its sexual nature, blind to the pleasure their hands produced because education and culture forbade acknowledgement of female desire. The hysteria industry grew to remarkable proportions. Major cities boasted clinics specializing exclusively in treating nervous women. Appointment books reveal that some patients visited weekly or twice a week for months or years. Physicians meticulously recorded each session, intensity of contractions, duration, and the patient's subsequent composure. Manuals instructed doctors to maintain discretion, shield women's modesty, and repeat sessions until symptoms were alleviated. The demand was immense. One New York physician advertised complete relief from female troubles and employed multiple assistants to keep pace with the endless queue of patients. Treating hysteria became a full-time occupation, exhausting physicians' hands and minds alike. Hysteria shaped social expectations, defined proper female behavior, and influenced medical research for decades. Women who defied norms risked being labeled hysterical. Those who suffered in silence risked prolonged distress. Hysteria became both a symptom and a metaphor, representing society's fear of the female body and mind. And yet, within this darkly clinical framework, a paradox emerged. Women discovered, often without words, that treatment provided relief beyond the intended medical outcome. Secretly, the sessions fulfilled desires doctors could not name, granting autonomy and sensation within a society that denied both. In short, hysteria was more than a disease. It was a lens through which Victorian society viewed women. Its diagnosis codified ignorance, masked sexual denial, and justified practices ranging from the absurd to the morally questionable. It allowed doctors to believe they were curing disease while performing acts that fulfilled a human need society refused to acknowledge. For millions of women, hysteria became a lifetime companion, a socially sanctioned path to both shame and relief, chronicling an era in which medical science, culture, and gender collided with astonishing consequences. By the time the Victorian era arrived, the ancient idea of the wandering womb had taken on a more clinical guise, yet its shadow lingered over women's health. Greek physicians had long theorized that a restless uterus could roam through the body, pressing on organs and driving women into fainting, anxiety, or irritability. Plato's metaphorical animal within an animal may have been poetic, but centuries later it became terrifyingly literal in the eyes of doctors. By the 1800s, the wandering womb had vanished from medical textbooks, but hysteria, the catch-all disease born from this myth, remained. Its diagnosis evolved, but the cultural and clinical confusion surrounding female bodies persisted, making science and superstition nearly indistinguishable. Victorian physicians viewed women through a lens shaped by curiosity, prejudice, and fear. Female physiology was considered fragile, dominated by reproductive organs. Emotional instability, restlessness, or malaise was interpreted as uterine dysfunction rather than social pressure, stress, or psychological strain. A young woman suffering from insomnia or irritability became a medical case rather than a human being. The literature of the era reads like a catalog of imagined maladies. Hysteria could present as fainting, muscle spasms, palpitations, irritability, or sexual curiosity. If a woman laughed too loudly, displayed ambition, or expressed anger, she risked being labeled hysterical. The same behavior in a man might be called spirited, but for a woman, it was proof her uterus was misbehaving. Doctors relied on observation, questioning, and strict adherence to procedure. Yet despite the scientific veneer, understanding was limited. There were no objective tests, no lab markers, nothing beyond subjective interpretation filtered through society's biases. Victorian culture demanded modesty, compliance, and silence from women, while pathologizing deviation. Hysteria became a mirror of society's fear of female autonomy, a disease elastic enough to include nearly every woman at some point. Treatment only amplified the confusion. Manuals provided meticulous instructions for procedures, many involving intimate manipulation. Pelvic massage, hydrotherapy, and rest cures were prescribed to calm the nerves and restore balance to a body thought to be ruled by reproductive organs. Physicians described techniques clinically, noting pressure, motion, and positioning, emphasizing discretion and propriety. Yet what doctors recorded as hysterical paroxysm, sudden muscle contractions, flushing and release, was orgasm. Textbooks described it clinically, oblivious to the sexual act. This wasn't deliberate denial, it was cultural blindness codified into education. Victorian doctors genuinely believed female sexuality was negligible. Their hands were instruments of therapy, not pleasure, even as they unknowingly delivered both. This disconnect created irony and opportunity. The sessions relieved symptoms, both physiological and psychological, otherwise ignored or trivialized. Appointment books from New York, London, and Paris show women attending weekly, sometimes twice weekly, for months or years. Physicians meticulously recorded each session, noting intensity, duration, and the patient's composure. Manuals emphasized repetition until symptoms subsided, producing a systematized, exhausting regimen. Doctors' hands grew tired, yet the industry thrived. Some practices specialized solely in hysteria treatment, employing assistants to keep pace, advertising complete relief from female troubles as a mark of prestige. Beyond clinical walls, hysteria reinforced societal control. Women were guided into passivity, compliance, and silence, while doctors claimed authority over bodies they barely understood. Diagnosis codified ignorance, allowing professionals to maintain authority even as treatment blurred the line between therapy and unintended pleasure. The acts intended to cure reinforced social norms. The woman remained docile, the doctor professional, and culture denied female desire. Yet paradoxically, patients discovered relief beyond what physicians recognized, a quiet rebellion inside propriety. Hysteria represented both science and spectacle. It codified anatomical confusion, misapplied ancient myths, and justified intimate procedures under the banner of medicine. The wandering womb had vanished from textbooks, but its echoes lingered in every nervous patient, every flushed face, and every record of muscular paroxysm. The paradox of hysteria, its simultaneous pathologization and inadvertent gratification, exposed the depths of cultural denial. Women endured, adapted, and sometimes thrived within a system designed to control them, while doctors remained convinced of their clinical purpose. The evolution from wandering wombs to Victorian hysteria illustrates a collision of myth, medicine, and society. It is a story of misunderstanding codified as expertise, of fear dressed as science, and of human need masquerading as disease. For millions of women, hysteria remained a lifelong companion, its treatment a secret relief unknown even to those administering it, marking an era in which medical knowledge and cultural assumption were inseparable and utterly confounding. By the mid-19th century, Victorian society had perfected the art of denial. Female sexuality was treated as both non-existent and dangerous, a taboo lurking behind every corset and lace collar. The prevailing belief among physicians was straightforward. Women were delicate, morally superior, and largely immune to sexual desire. Any deviation from this ideal, a glance too bold, a sigh too deep, a flush on the cheek was suspect, evidence of disease or moral failing. Sexual repression was not merely social, it was institutionalized. The education system, literature, religious instruction, and medical schools all reinforced the notion that women's bodies were passive, their pleasures negligible, and their erotic impulses, if acknowledged at all, an embarrassment to medical propriety. Doctors were products of this culture, and their ignorance was codified into textbooks and medical manuals. Female anatomy was poorly understood, particularly the clitoris, which was often omitted or described as vestigial and functionless. Physicians were trained to view reproductive organs purely in terms of procreation, while pleasure, desire, and erotic sensation were dismissed as irrelevant distractions. A woman's complaints of nervousness, fatigue, irritability, or vague discomfort were invariably interpreted through the lens of this repression. They were not expressions of stress, unhappiness, or sexual frustration. They were symptoms of a malfunctioning uterus, evidence of hysteria. The cognitive dissonance is staggering. doctors routinely performed intimate procedures touching, manipulating, massaging genitalia without ever conceptualizing them as sexual acts. Handwritten notes in clinical journals meticulously documented muscular contractions, flushing, and relaxation, describing these phenomena clinically as hysterical paroxysm, a physiological event meant to relieve tension. Yet the Victorian mind could not allow a connection to sexual climax. Pleasure existed in theory, but never in practice. It was unnameable, unthinkable, and invisible, even when occurring literally beneath their hands. Even medical pioneers were ensnared in this ignorance. Dr. John Harvey Kellogg, inventor of cornflakes and a crusader against masturbation, regularly prescribed vibrators and manual stimulation to treat hysteria in his female patients. At the same time, he demonized sexual self-expression, promoting extreme dietary and behavioral controls to suppress it. The paradox was complete. Women experienced relief, but doctors remained convinced they were performing therapy, not facilitating desire. The culture of repression had blinded the most educated, most meticulous practitioners to the reality, staring them in the face. This denial was reinforced by societal norms. Women were expected to maintain modesty, decorum, and obedience, especially in medical settings. Their voices were undervalued. Their descriptions of sensation were disregarded or sanitized. If a woman hinted at sexual pleasure, it was either ignored, disbelieved, or pathologized. The medical establishment created a system in which female bodies were objects of study and control, rather than subjects with their own experiences. The language of medicine clinical, detached, precise, masked what was actually happening. Doctors could write in their journals about nervous discharge or muscle contractions, while treating sexual frustration in the most direct way possible, all without ever acknowledging it. Education played a central role. Anatomy classes emphasized reproductive structures for procreation and hygiene, but left out discussion of sexual pleasure. Textbooks claimed that women had minimal sexual sensation, often implying that orgasm was unnecessary or unnatural. Medical students learned how to treat hysteria mechanically, without context or curiosity. The result was generations of physicians performing explicit sexual acts in the name of science, yet remaining oblivious to the human response they were eliciting. Repression extended beyond the doctor's office. Literature, etiquette manuals, and religious teachings combined to silence female sexuality entirely. Women internalized this denial, often feeling shame for natural responses or curiosity. Hysteria became a socially acceptable outlet for these suppressed experiences, providing relief under the guise of therapy, without acknowledgement of pleasure or desire. A visit to the doctor was simultaneously medical, sexual, and clandestine, a secret rebellion against the strictures of propriety. In this landscape of ignorance, cultural blindness, and repression, the stage was set for one of the most bizarre episodes in medical history. Physicians, convinced of their moral and scientific authority, inadvertently facilitated acts of sexual gratification while codifying female desire as pathology. Victorian sexual repression did not merely misinform medical practice, it actively created it, shaping diagnoses, treatments, and experiences for millions of women. The intersection of culture, education, and medicine produced a system that could treat sexual frustration as disease, while never once naming it as such. By the 1,850 seconds, pelvic massage had become the cornerstone of hysteria treatment. Manuals and textbooks outlined the procedure with meticulous clinical detail. The patient, partially undressed but modestly draped, would recline on a padded examination table. The physician applied scented oils and began a methodical manipulation of the vulva. Circular motions, pressure, and persistent rhythm continued until the patient experienced what doctors recorded as hysterical paroxysm. In reality, these were orgasms, but Victorian medical culture was blind to the truth, framing every muscle spasm, facial flush, and release as physiological, not erotic. The rationale was simple, if deeply misguided. Hysteria was a disease of suppressed nervous energy or reproductive dysfunction. Relieving this tension restored equilibrium, Manuals describe the procedure clinically, emphasizing discretion, repetition, and precision. Physicians were instructed to shield the patient's modesty, noting contractions, skin flushing, and relaxation with meticulous care. One could spend an hour inducing paroxysm, yet the act remained entirely medical in the practitioner's mind. There was no acknowledgement of pleasure, no admission that human desire could coexist with therapy. Demand for these treatments skyrocketed. Appointment books from London, New York, and Paris reveal women attending weekly, sometimes twice weekly, for months, even years. Major cities boasted clinics devoted entirely to hysteria, some employing multiple assistants to keep pace. Physicians meticulously documented each session, duration, intensity, patient composure, and symptom relief. Hydrotherapy, rest cures, and dietary regimens often complemented pelvic massage, but the manipulation of genitalia was central. Doctors' hands were exhausted. Manuals warned that treatment required stamina, skill, and patience. Pelvic massage was not only a therapeutic intervention, it was a cultural instrument. Women internalized modesty and compliance, while receiving what was simultaneously relief and covert gratification. Doctors maintained authority and professional distance, interpreting responses as clinical data, never questioning the implications. Victorian society had created a system in which female pleasure existed only as an unacknowledged symptom, a side effect of disease treatment rather than an experience in its own right. The paradox extended further. Wealthy patients could receive house calls, while spas and hydrotherapy centers provided communal yet discreet treatment. Bathhouses in Germany and England became hubs for nervous women, their days filled with water treatments designed to soothe the body and calm the nerves. Some facilities even incorporated mechanical devices, early vibrators, designed to reduce strain on physicians' hands, further codifying the practice as a medical procedure, rather than an act of sexuality. Medical professionals documented the procedure with exhaustive clinical precision. Apply oil to the vulva, advised one manual. Massage with firm circular motion until contraction occurs. Maintain rhythm. Observe patient's complexion and musculature. Repeat until relief is achieved. The language is clinical, detached, and careful, but the act it describes is unmistakably sexual. Despite this, physicians remained convinced that the hands of science were neutral instruments of therapy. Patients were expected to maintain composure, rarely speaking of sensation, while doctors recorded every minute detail in cold, clinical prose. The unspoken tension between bodily pleasure and social propriety created a bizarre theater of control, where both patient and doctor played roles dictated by culture, ignorance, and authority. Some physicians even cautioned against overindulgence, fearing that too many sessions might excite the patient's nervous system instead of calming it. Manuals warned that certain personalities, especially imaginative, passionate, or disobedient women, required slower treatment, shorter sessions, or alternating therapies to prevent excessive stimulation. This clinical language masked an unspoken reality. The very act of touch had the power to awaken sensations society refused to acknowledge. Women quickly learned, consciously or unconsciously, how to manipulate these sessions for greater relief, subtly negotiating autonomy within a rigid patriarchal system. Pelvic massage, like hysteria itself, exemplified the collision of ignorance, repression, and medical authority. Women discovered relief, doctors recorded success, and society remained oblivious. The procedure codified cultural denial. Female desire existed only as a symptom of disease, yet it was powerful enough to shape treatment, clinic organization, and even emerging technology. In this strange, secretive system, millions of women experienced clandestine empowerment, while the medical establishment remained blind to the very forces it had unleashed. Enforcing compliance while delivering unintended pleasure, a paradox only Victorian society could create. By the mid-19th century, physicians treating hysteria faced a unique, exhausting challenge: their own bodies. Pelvic massage, the standard treatment for the disease, required hours of precise, repetitive manipulation, demanding stamina, dexterity, and unwavering attention. Manuals cautioned that fatigue could compromise efficacy, yet appointments rarely allowed for respite. Doctors' hands became instruments of therapy, endurance, and, unknowingly, pleasure, worn down by the relentless rhythm of treatment. This physical burden was rarely acknowledged in print, but it was central to the daily reality of any practitioner in the hysteria trade. Medical culture framed the work as purely clinical, even noble, yet the strain was undeniable. Practitioners recorded sessions lasting from 30 minutes to over an hour, sometimes multiple times a day. In major cities like London, New York, and Paris, clinics thrived on volume. Physicians were expected to treat dozens of patients weekly, their hands in near constant motion. Manuals emphasized the need for stamina, recommending exercises for finger strength and strategies for maintaining rhythm over extended periods. Hands, wrists, and forearms ached, yet the prevailing belief demanded that doctors suppress any complaint, preserving the image of professional authority and detachment. The dilemma extended beyond physical fatigue. Doctors operated within a cultural framework that denied acknowledgement of female sexual response. Every contraction, every flushed cheek, was recorded as a clinical outcome, never recognized as erotic. Physicians were trained to maintain emotional distance, to view patients as cases rather than humans. Yet the paradox was impossible to ignore. Their hands were delivering pleasure, even if society forbade them from admitting it. Diaries and letters, rare as they are, hint at the strained moments of bewilderment, frustration, and discomfort, at the contradictions inherent in their work. Ethical ambiguity compounded the physical toll. Doctors had to reconcile their Hippocratic oath with treatments that demanded intimate contact. Manuals insisted on discretion and propriety. Hands must be gentle but effective, touch firm but professional. A lapse in either could compromise results or invite scandal. Physicians were caught in a tightrope of morality, medical expectation, and cultural repression, their personal experience often at odds with public persona. The act of healing became a source of tension, anxiety, and self-doubt. Some tried mechanical innovations to relieve their burden. Early vibrators, steam-driven devices, and mechanized massagers were introduced in clinics, intended to reduce manual strain while maintaining therapeutic outcomes. These technologies were celebrated in medical journals as breakthroughs, yet they also reinforced the strange irony of the profession. Tools were designed to perform tasks doctors could not fully comprehend in context, acting as extensions of hands already pushed to the brink. The pressure was amplified by patient expectations. Women sought relief that doctors were socially forbidden to frame as sexual. Sessions could not be rushed. Efficacy was measured in paroxysms, calm post, treatment composure, and meticulous notes. The repetition required patience, focus, and emotional fortitude. Every session risked error. Every missed contraction threatened credibility. And yet, the practitioner's own limits were invisible to the broader medical community. Fatigue was personal, pain private, and yet failure could have public consequences. This dilemma, physical exhaustion, moral ambiguity, and cultural contradiction, defined the professional experience of hysteria treatment. Manuals and journals instructed doctors in technique, rhythm, and observation, yet they could not provide guidance for the unspoken conflicts inherent in the act. Delivering involuntary pleasure while maintaining authority, enduring the repetitive strain of therapy, and remaining blind to the paradox that defined their own role. In private, many physicians developed coping strategies, alternating hands, pacing sessions, or relying on assistants to share the load, though such measures were rarely documented formally. Ultimately, the doctor's dilemma was emblematic of the broader contradictions of Victorian medicine. Hysteria treatment demanded physical labor, moral vigilance, and emotional detachment while producing results that defied clinical understanding. Hands at the brink of collapse were a literal and symbolic representation of the strain imposed by a system rooted in ignorance, repression, and cultural denial. Physicians endured, women experienced relief, and society remained blissfully unaware of the human tension underlying every treatment session. The paradox of healing and pleasure, exertion and denial, would define the era, leaving both doctors and patients caught in the strange, exhausting theater of Victorian medicine. While pelvic massage dominated private consultations, public treatment of hysteria often took a watery form. Hydrotherapy, the therapeutic use of water, became a hallmark of Victorian spas, bathhouses, and clinics. Patients submerged themselves in tubs, doused under cascading showers, or reclined in pools of varying temperatures, all under the careful supervision of attendants trained to measure duration, temperature, and body response. Water, society was told, could calm nerves, restore equilibrium, and soothe the restless female body. In reality, hydrotherapy offered both relief and a socially acceptable avenue for physical sensation, though the erotic undertones remained largely unacknowledged by medical professionals. Spas across Europe and North America marketed their treatments as modern, scientific solutions to nervous disorders. Cities like Baden-Baden, Bath, and Vichy boasted facilities equipped with hot and cold baths, mineral springs, and steam rooms. Physicians recommended regimented schedules, alternating hot and cold baths, extended soaking, and timed showers, designed to regulate circulation and calm perceived uterine agitation. Sessions could last for hours, often with multiple daily. While pelvic massage dominated private consultations, public treatment of hysteria often took a watery form. Hydrotherapy, the therapeutic use of water, became a hallmark of Victorian spas, bathhouses, and clinics. Patients submerged themselves in tubs, doused under cascading showers, or reclined in pools of varying temperatures, all under the careful supervision of attendants trained to measure duration, temperature, and body response. Water, society was told, could calm nerves, restore equilibrium, and soothe the restless female body. In reality, hydrotherapy offered both relief and a socially acceptable avenue for physical sensation, though the erotic undertones remained largely unacknowledged by medical professionals. Spas across Europe and North America marketed their treatments as modern, scientific solutions to nervous disorders. Cities like Baden-Baden, Bath, and Vichy boasted facilities equipped with hot and cold baths, mineral springs, and steam rooms. Physicians recommended regimented schedules, alternating hot and cold baths, extended soaking, and timed showers, designed to regulate circulation and calm perceived uterine agitation. Sessions could last for hours, often with multiple daily visits, combining relaxation with a sense of ritualized discipline. The emphasis on protocol mirrored the clinical rigor of private massage, transforming water into both therapy and spectacle. The act of immersion became part of a performance. Patients followed strict routines, attendants meticulously timed procedures, and the entire experience was framed as science in action. Hydrotherapy's appeal extended beyond the physical. Women who had long been confined to restrictive households or socially prescribed roles discovered in these baths a rare sense of autonomy. Within the structure of propriety attendants, modesty drapes, and precise instructions, they could experience bodily awareness and relief previously denied. Medical manuals insisted on observation, note skin tone, pulse, respiration, and visible tension. Yet attendants often witnessed subtle reactions, a flush of pleasure, relaxation, or even involuntary muscular twitching that went unrecorded. These spas became spaces where female bodies were publicly regulated but privately liberated, an ironic inversion of control. Mechanical devices and water jets began to complement traditional baths, delivering vigorous streams of water targeted at areas considered hysterically tense. Physicians regarded these as technological aids, emphasizing standardization and efficiency. Patients reported sensations described as invigorating, soothing, or strangely pleasurable, though manuals never acknowledged sexual response. Hydrotherapy bridged the gap between medical treatment and leisure, combining the ritual of cure with an experience of bodily agency, however constrained by social expectation. In some advanced establishments, attendants or physicians could adjust jet pressure or temperature according to the patient's perceived nervous tension, creating a precise but intimate form of therapy. Diet, exercise, and rest were often integrated into hydrotherapy programs. Spas encouraged walks in gardens, massage sessions, and regulated mealtimes, reinforcing a holistic approach to nervous female health. The underlying belief persisted. Hysteria was not merely mental but embodied, a disorder of the nerves, the uterus, and the delicate female constitution. By immersing women in controlled water treatments, physicians and attendants believed they could realign body and mind, all while maintaining a veneer of propriety and scientific legitimacy. The sensory experience of warm or cold water became inseparable from the clinical objective, even as the patient's own bodily pleasure remained socially invisible. Yet the social paradox was profound. Hydrotherapy offered women structured independence, a chance to move, breathe, and experience sensation, yet always under the surveillance of authority. It codified both care and control. By the late 19th century, physicians treating hysteria faced a relentless problem. The manual pelvic massage, though effective, was exhausting, time-consuming, and physically taxing. Doctors spent hours each day performing delicate manipulations on patients, often inducing hysterical paroxysms repeatedly. The growing demand for treatment, combined with increasing urban populations and the prevalence of hysteria diagnoses, created an urgent need for a more efficient method. Into this environment, the first mechanical vibrators emerged. These devices were conceived not as instruments of pleasure, but as tools to standardize and accelerate therapy, relieving doctors' hands while maintaining clinical authority. Early vibrators were cumbersome, steam-powered machines, resembling small industrial engines more than medical instruments. Physicians used them in private consultation rooms, applying the devices directly to the vulva or pelvic region in carefully controlled sessions. Manuals emphasized precision, duration, pressure, and rhythm were meticulously recorded, with practitioners instructed to observe muscle contractions, skin tone, and the patient's post-treatment composure. What Victorian doctors called a hysterical paroxysm was, in fact, orgasm, yet the manuals remained entirely clinical, describing physiological effects without acknowledging sexual sensation. In their eyes, the machine's hum and the patient's responses were entirely therapeutic. The invention of the vibrator represented both technological ingenuity and cultural denial. Society refused to recognize female sexual pleasure, while medicine codified hysteria as a disease of the nervous system and reproductive organs. The vibrator, therefore, became a paradoxical solution. It allowed women to experience relief, sometimes intensely pleasurable, while doctors maintained a sense of moral and clinical propriety. In this way, technology simultaneously reinforced and subverted the social norms of the Victorian era, creating an invisible intersection of therapy, repression, and secret gratification. Electrical innovations in the 1,880 seconds and 1,890 seconds transformed these early machines. The first electrically powered vibrators replaced the bulky steam engines, making them quieter, lighter, and easier to use. Physicians could now treat more patients in less time, while patients received consistent therapy. Clinics in London, Paris, and New York adopted these new devices quickly, often marketing them as symbols of modern scientific medicine. The electrified vibrator was presented as a marvel of progress, a cutting-edge solution to a medical dilemma, yet its true effects on the patient's body were deliberately obscured in manuals, journals, and public discourse. Inventors patented these devices under clinical terminology, ensuring they could be marketed to doctors and hospitals without arousing social or moral suspicion. Words like nervous relaxer, pelvic massager, or muscle stimulator masked the act's sexual nature. In advertisements aimed at physicians, the emphasis was always on efficiency, hygiene, and the machine's ability to relieve symptoms associated with nervous exhaustion, irritability, and female malaise. The medical profession embraced these devices as tools of progress, largely blind to the pleasure produced, because acknowledging such effects would have undermined both cultural norms and professional authority. In addition to private consultations, vibrators began appearing in spa and hydrotherapy clinics, integrated into regimented programs for women. Paired with baths, rest, and diet, mechanical stimulation became part of a broader therapeutic framework. Manuals instructed attendants and physicians on safe usage, ensuring discretion while maximizing efficacy. Patients often experienced multiple sessions, sometimes daily, with every response recorded meticulously. While the official narrative framed these sessions as strictly medicinal, Women frequently reported relief extending beyond nervous tension, increased calm, relaxation, and even subtle sexual satisfaction effects that doctors never acknowledged in print. The birth of the vibrator also marked the beginning of a quiet shift in women's relationship to medical authority. While doctors maintained outward control, the device allowed women a form of bodily autonomy, however constrained. They could experience sensations unspoken, explore relief unavailable elsewhere, and, in some cases, assert subtle influence over treatment pace and intensity. The vibrator thus existed at the crossroads of invention, repression, and empowerment, a technological marvel born of medical necessity, yet inseparable from cultural denial. By the end of the 19th century, the vibrator had moved from cumbersome steam engines to more compact, practical devices, laying the foundation for both professional and domestic use. Its invention reflected the intersection of medical innovation, social repression, and human desire, revealing a culture simultaneously obsessed with control and unable to acknowledge the very sensations it produced. The mechanical hum of the vibrator, carefully framed as a clinical tool, carried within it the unspoken paradox of relief, pleasure, and societal denial. By the early 20th century, the vibrator had transitioned from a steam-powered novelty to a compact electrically powered device, expanding its use far beyond large clinics and spas. Physicians could now bring treatment into private homes or smaller medical offices, allowing more patients to receive therapy discreetly. Manuals outline precise protocols. The device should be applied to the vulva or adjacent areas, set to specific intensities, and used for a controlled duration. Doctors emphasized hygiene, patient comfort, and the observation of physical responses such as flushing, muscular contractions, and relaxation. While the language remained clinical, the results were unmistakably pleasurable, producing what Victorian medical texts continued to term hysterical paroxysm. Doctors' offices became central hubs for mechanical therapy. Chairs, padded tables, and privacy screens created an environment where patients could recline and be treated efficiently. Physicians often scheduled multiple appointments in succession, using vibrators to induce relief more quickly than manual massage could allow. The efficiency of electrical devices meant that clinics could serve more patients without exhausting the doctor's hands or staff. Attendance records from London, Paris, and New York show women visiting once or twice weekly, sometimes over the course of years. Each session was meticulously recorded: duration, intensity, patient composure, and symptom relief. The meticulous documentation underscored the clinical seriousness of vibrators, masking the sexual dimension inherent in their use. Mechanical therapy was also integrated into domestic medicine. Wealthy families could purchase personal vibrators, allowing house calls to be replaced with self-administered treatments under the guidance of written manuals. Advertisements for home devices stressed efficiency, convenience, and medical legitimacy, avoiding mention of the sensations they produced. Manuals instructed users on placement, duration, and speed, using strictly clinical terminology. Women, however, quickly discovered that the machines provided more than medical relief. They delivered discreet, pleasurable experiences in the privacy of the home. The cultural tension between propriety and sensation was heightened. What was presented as therapy became, in effect, a hidden form of sexual empowerment. Doctors and patients both navigated a delicate balance. Physicians had to maintain authority and adhere to professional standards, while patients needed to demonstrate modesty and compliance. Manuals emphasized observation and restraint, note physical responses, record the appearance of contraction, and ensure no overt expression of sensation. At the same time, patients who understood their own reactions could manipulate sessions to their advantage, extending duration or experimenting with intensity. This quiet negotiation of power transformed the doctor-patient relationship into a complex dance. The patient retained subtle control, while the physician maintained the illusion of authority. The paradox of pleasure disguised as therapy became a defining feature of domestic vibrator use. Beyond individual homes, some spas and private clinics integrated vibrators into communal treatment spaces. Mechanically assisted hydrotherapy rooms or massage salons allowed multiple patients to receive treatment simultaneously. The devices were framed as modern instruments, part of a scientific approach to nervous disorders. Attendants supervised use, monitored responses, and ensured conformity to protocol. While everything appeared clinical and regimented, patients often discovered personal relief beyond what the manuals intended. These communal spaces reinforced societal norms of modesty and observation, yet they simultaneously offered women an unacknowledged arena of bodily awareness and sensation. Vibrators in medical and domestic settings also influenced broader perceptions of female health. They reflected the era's obsession with efficiency, mechanization, and scientific legitimacy. At the same time, the devices embodied the contradictions of Victorian and Edwardian culture, the acknowledgement of bodily need without acknowledgement of sexual agency. Women's relief was framed as symptom management, their pleasure invisible, their autonomy unspoken. The vibrators created a space where private desire and public propriety collided, producing both compliance and subversive empowerment within a framework designed to deny it. By the 1920 seconds, vibrators had become widely recognized as standard tools for hysteria treatment. Clinics continued to document sessions with meticulous attention to protocol, while home use expanded access for women who wished to maintain privacy. Manuals, advertisements, and doctors' notes emphasized efficiency, therapeutic effect, and adherence to procedure, never acknowledging the pleasure that was inseparable from use. Women learned to navigate this paradox, experiencing relief and sensation while outwardly conforming to societal norms. Vibrators had moved from the clinic to the home, cementing their role as a mechanical solution to hysteria that carried with it a hidden dimension of empowerment. Behind the closed doors of clinics and the privacy of homes, many women documented their experiences with hysteria and its treatments. Diaries, letters, and personal notes provide an invaluable window into the world that medical manuals sought to sanitize. While physicians focused on clinical outcomes, duration of paroxysms, skin flush, muscle contraction, patients recorded sensation, emotion, and reflection. Their writings reveal a mixture of relief, embarrassment, curiosity, and even secret amusement. The discrepancy between clinical records and personal accounts underscores the deep tension between medical authority and individual experience, offering rare insight into a world where bodies and desires were regulated, yet never fully acknowledged. For some women, diaries became a private archive of resistance. Noting the sensations produced by pelvic massage or mechanical therapy, patients often described them in euphemistic language, careful not to breach the boundaries of propriety. One anonymous Victorian diary recounted the relief of a long, exhausting treatment, noting the release of tension and the warmth of comfort, phrases loaded with subtle meaning. Another woman wrote candidly of the private enjoyment she discovered during hydrotherapy sessions, expressing both guilt and pleasure. These writings illustrate how women navigated a cultural landscape that denied acknowledgement of female desire, converting clandestine experiences into personal testimony. Such writings were often hidden, passed to descendants, or left in forgotten drawers, ensuring the secret history of sensation remained obscured from the public eye. Patient letters to physicians sometimes betray a mixture of dependency and subtle control. Women requested adjustments in duration, intensity, or frequency of treatments, negotiating terms within the rigidly prescribed medical framework. While doctors documented symptom relief and compliance, women's correspondence occasionally reveals the unspoken satisfaction and agency achieved through therapy. These letters demonstrate that patients were not passive recipients of treatment, but active participants, capable of influencing the process. Even within the strictures of societal expectations, women carved out a measure of autonomy, manipulating medical practice to meet personal needs. In some cases, these letters hint at humor, private rebellion, or coded commentary about the absurdities of their treatment. The diaries also expose the emotional landscape of Victorian patients. Many entries describe anxiety, fatigue, and social pressure, illustrating the psychological burden of living under constant surveillance and judgment. Treatments offered relief, yes, But they also created dependence on medical authority. Women wrestled with the paradox of therapy. Relief intertwined with social expectation, pleasure cloaked as disease management. Personal writings often contain expressions of gratitude, mixed with exasperation, revealing the complex interplay of trust, necessity, and subtle rebellion in the doctor-patient relationship. Through these documents, the strain of social conformity and the desire for autonomy become palpable. Importantly, diaries highlight the diversity of experience. Not all patients welcome treatment. Some found it invasive, uncomfortable, or morally troubling. Others embraced it as a rare opportunity to explore bodily sensation within socially permissible confines. Hydrotherapy, pelvic massage, and vibrators elicited responses ranging from discomfort to secret joy, creating a spectrum of experience invisible in clinical records. By giving voice to these varied reactions, diaries complicate the narrative of hysteria treatment, revealing it as a human rather than purely medical phenomenon. In this way, women's writings challenge assumptions about passivity, exposing nuanced negotiations of power, secrecy, and agency. Medical historians now rely heavily on these personal documents to reconstruct the lived realities of women subjected to hysteria therapy. Diaries, letters, and memoirs offer context missing from textbooks. The quiet strategies women employed, the emotions suppressed during treatment, and the subtle forms of empowerment achieved. Through these voices, the sanitized clinical record is transformed into a layered, human story, one that acknowledges both suffering and agency. They reveal how women maintained control over their own narratives, shaping memory and history, even when their bodies were constrained. Ultimately, patient diaries illuminate the interplay of culture, medicine, and personal experience. They show that the history of hysteria cannot be told solely through manuals, physician notes, or institutional protocols. Women's voices, often hidden or coded, reveal the paradox of treatment. Relief and pleasure coexisted with societal judgment, authority, and secrecy. Diaries and letters are testament to the ingenuity, resilience, and humanity of those navigating a medical world that claimed to cure disease while denying the full reality of human experience. Through these personal writings, we gain a rare and vivid window into a hidden dimension of Victorian life, where the voice of the patient silently resisted erasure. Victorian physicians operated in a world of contradictions, balancing emerging scientific knowledge with entrenched cultural beliefs. Hysteria, a catch-all diagnosis, demanded complex treatment strategies, yet the very experts tasked with curing it were blinded by their own assumptions. Doctors were convinced of their clinical purpose, while simultaneously ignoring evidence that did not align with prevailing notions of female physiology and morality. Pelvic massage, hydrotherapy, and vibrators were administered as remedies, all carefully codified in manuals. Yet their true effects, physiological relief intertwined with sexual pleasure, remained invisible to the medical mind. This cognitive dissonance, the simultaneous acceptance of contradictory truths, underpinned nearly every aspect of hysteria treatment. Physicians often justified intense, invasive, or prolonged therapies, all while genuinely believing they were acting in the patient's best interest, creating a system where ignorance was institutionalized and self-reinforcing. Physicians' education reinforced their narrow perspective. Medical schools taught anatomy and physiology with a focus on reproduction, and cultural norms further entrenched the denial of female sexual agency. Women's bodies were seen as delicate, erratic, and prone to dysfunction, yet their desires were deemed negligible or morally threatening. Manuals described procedures in meticulous clinical language, emphasizing discretion, repetition, and observation. Every contraction, flush, and paroxysm was logged as a symptom or evidence of cure. Physicians remained confident in the scientific legitimacy of their interventions, unaware that their practices often produced effects they themselves could not name. Blindness to this reality allowed treatments to flourish unquestioned, and the medical profession continued for decades without confronting the possibility that pleasure and therapy were intertwined. Patient testimony exposes the contrast between clinical narrative and lived experience. Diaries, letters, and personal writings reveal that women recognized the dual nature of treatments, relief from nervous tension alongside clandestine pleasure derived from procedures. Women were aware of sensations unacknowledged by their doctors and often developed subtle strategies to maximize benefit while maintaining propriety. In this way, the cognitive dissonance of physicians was complemented by the ingenuity of patients, creating a system in which authority and agency existed in constant tension. Even as medical professionals documented apparent improvement, women navigated private understanding of their own bodies, marking a hidden resistance that never appeared in medical records, but profoundly shaped daily experience. The dissonance was amplified by the cultural construction of female virtue. Doctors could not reconcile the idea that sexual satisfaction might exist outside marital or reproductive contexts. Treatments were framed as medical necessities, yet they inadvertently provided experiences culturally condemned as indulgent. Victorian society demanded modesty and restraint, while medical practices delivered unspoken gratification. Physicians' insistence on clinical detachment masked a profound misunderstanding. The body's response did not follow logic or cultural expectation. Blindness to this reality was not mere oversight, but a systemic feature of medical thought, reinforcing gendered hierarchies and maintaining authority over female bodies. Medical blind spots extended beyond therapy. Studies, reports, and textbooks relied on observation filtered through bias. Physicians interpreted paroxysms, flushed skin, and muscle contractions purely as pathological indicators. Any acknowledgement of pleasure or desire was deliberately ignored or rationalized as a physiological phenomenon. Manuals warned against overindulgence, emphasizing repetition and procedural fidelity, yet never addressed the reality of patient sensation. This dissonance legitimized invasive practices while shielding practitioners from ethical reflection. Blindness and rationalization became mutually reinforcing, allowing medicine to function as both relief and control, without confronting the human consequences of treatment. Ultimately, the cognitive dissonance of Victorian medicine illuminates a broader societal paradox. Physicians believed they were curing disease while remaining blind to fundamental truths of human experience. Cultural norms, scientific ambition, and personal bias combined to produce an environment where both practitioner and patient operated under conflicting understandings of treatment and effect. Blindness and rationalization created a world in which women's bodies became sites of both care and misunderstanding, shaping medical practice and societal perception for generations. Hysteria treatment, viewed through this lens, reveals the profound cost of cognitive dissonance, an era in which ignorance masqueraded as expertise and human experience was rendered invisible beneath clinical authority. The legacy of this disconnect would persist long after Victorian society faded, influencing medicine and attitudes toward female health for decades to come. While pelvic massage, hydrotherapy, and vibrators dominated most treatments for hysteria, some physicians resorted to far more extreme measures. Clitoridectomy, the surgical removal of the clitoris, emerged as one of the most radical and controversial interventions. The practice was justified under the guise of curing hysteria, preventing masturbation, and restoring moral virtue. Physicians argued that excising the organ would eliminate the source of nervous excitement, thus curing both physical and psychological ailments. Though shocking by modern standards, this procedure was rationalized as medical necessity, rooted in cultural anxieties about female sexuality and strict Victorian notions of morality. It demonstrates a grim reality. Women's bodies were viewed less as individuals' domains than as territories to be regulated, corrected, and controlled according to societal fears. Surgical manuals described the procedure in meticulous clinical detail, often emphasizing efficiency over safety or comfort. Patients, many of them young girls or adolescents, were restrained on operating tables while surgeons performed excision, frequently with little or no anesthesia. The manuals advised careful attention to bleeding, infection, and post-operative hygiene, yet the central claim was always therapeutic. Physicians justified clitoridectomy with a combination of moralistic and medical reasoning. Sexual desire was considered pathological, masturbation a dangerous habit, and hysteria a symptom of moral failing. Parents, institutional administrators, and sometimes the patients themselves were often convinced of the necessity of the procedure. In many cases, compliance was secured through authority, coercion, or fear, highlighting a system that subordinated bodily autonomy to medical and social ideology. The consequences of clitoridectomy were devastating and multifaceted. Physically, patients endured pain, infection, scarring, and permanent loss of sexual sensation. Many experienced chronic discomfort, recurring urinary tract problems, and complications related to healing. Psychologically, the trauma was profound. Diaries and letters from women who underwent the procedure reveal lasting feelings of shame, fear, and anger, often compounded by the sense that their experiences were unacknowledged and invisible. Some internalized the narrative of pathology, believing their bodies had been flawed or morally corrupt. Others resisted silently, cultivating private awareness of their own autonomy and sexuality despite coercion. The procedure left an enduring legacy of mistrust toward medical authority, exposing the human cost of intervention driven by ideology rather than evidence. Clitoridectomy also reflected broader social mechanisms of control. Hysteria was understood not only as a medical problem, but as a symbol of female deviation from societal norms. The procedure functioned as both therapy and moral enforcement, asserting control over sexual desire under the guise of care. Authority figures, physicians, educators, and parents collaborated, often unknowingly, to reinforce conformity. Extreme intervention became a form of social discipline, where deviation from prescribed behavior justified invasive measures. The operation demonstrates how medical practices could intertwine with cultural anxiety, transforming treatment into a tool of domination and suppression, and reinforcing the notion that women's bodies were subject to external authority. Despite its apparent prevalence, clitoridectomy was not universally accepted. Some physicians raised ethical concerns, questioned its necessity, or debated alternative treatments. Yet such opposition rarely halted the procedure, particularly in reformatories, schools, or psychiatric institutions, where female patients were especially vulnerable. The persistence of the practice illustrates the complex intersection of cultural fear, medical authority, and institutional power. It was both a symptom and cause of systemic misunderstanding, a treatment rooted in fear, executed under the pretense of science, and justified by ideology rather than empirical evidence. The gap between medical intent and human experience was vast, with patients bearing the consequences. Ultimately, clitoridectomy stands as one of the most extreme consequences of hysteria treatment. It embodies the intersection of medical ignorance, social repression, and coercive authority. Women's bodies became arenas for cultural anxiety, with invasive procedures rationalized by flawed theories, moral panic, and the belief in medical infallibility. The practice caused profound physical, emotional, and psychological harm, leaving scars that extended far beyond the operating room. It serves as a stark reminder of the dangers of unchecked authority, the cost of cultural blindness, and the human consequences of treating deviation as pathology. In examining this dark chapter of Victorian medicine, one confronts the limits of expertise divorced from empathy, and the high price paid by those caught in the crossfire of ideology and clinical ambition. By the late Victorian era, hysteria had grown from a peculiar medical curiosity into a sprawling, lucrative industry. What began as a diagnosis for fainting, irritability, or vague complaints had mutated into a structured system of treatment, clinics, manuals, and mechanical aids. Major cities like London, Paris, and New York were dotted with specialized facilities, each catering to nervous women who came seeking relief that was, in reality, as much about compliance and spectacle as it was about medicine. The hysteria industry thrived on social fear, cultural ignorance, and a peculiar medical obsession. The female body was both fragile and inscrutable, and it demanded endless attention from doctors willing to administer treatments that were at once intimate, mechanical, and socially sanctioned. Physicians meticulously chronicled each patient's symptoms and treatments, Appointment books, sometimes spanning decades, recorded paroxysms, duration of procedures, skin flushing, and subsequent comportment. Manuals dictated precise methods: pelvic massage with oils, hydrotherapy, strict rest cures, and dietary regimens designed to calm the nerves. Each entry reinforced a system of control. Women were instructed to comply, maintain decorum, and endure treatments that oscillated between therapeutic intent and socially oblivious erotic stimulation. Doctors genuinely believed in their scientific mission, unaware that their hands, baths, and early mechanical devices were delivering pleasure cloaked as medical necessity. The industry was not just confined to private clinics. Spa towns, public bathhouses, and hydrotherapy centers advertised their services as modern, scientifically validated solutions to nervous disorders. Facilities featured regimented schedules, alternating hot and cold baths, mechanical massage devices, and prolonged soaking sessions. In theory, these treatments restored equilibrium to a body considered dominated by reproductive organs and delicate nerves. In practice, they created spaces where women could navigate bodily sensation under the veneer of propriety, where medical observation intersected with subtle autonomy, and where private relief occurred in the shadow of public oversight. Economic incentives amplified the industry's scale. Clinics employed assistants to manage the growing patient load. Some doctors built entire practices around hysteria, gaining reputations as specialists in female nervous disorders. The proliferation of manuals, advertisements, and instruments ensured that the treatments were codified, repeatable, and almost impossible to escape. Patients, whether visiting weekly or daily, became part of a system designed to extend therapy indefinitely. The industry capitalized on the elasticity of the hysteria diagnosis. It could encompass any symptom, emotion, or deviation from social expectation, effectively creating a perpetual demand for treatment. Yet beneath the veneer of medical authority, the hysteria industry reflected a cultural paradox. Women were simultaneously pathologized and relieved. Desire was denied and yet experienced. Treatments like pelvic massage or mechanical stimulation were framed as clinical interventions, but they created spaces for clandestine bodily agency. The very system that sought to control female bodies paradoxically enabled a subtle form of rebellion. Appointment schedules, bathhouse protocols, and mechanical devices became instruments of both regulation and liberation, illustrating how social repression and medical practice could coexist in uneasy harmony. Medical professionals themselves were caught in cognitive dissonance. They documented sensations, contractions, and relief with meticulous precision, never acknowledging that what they measured was also pleasure. The manuals, journals, and advertisements reinforced a narrative in which the female body was a site of illness, not desire, yet the treatments consistently produced results the medical establishment could not classify. Patients learned, often intuitively, to exploit the system, extending sessions, engaging attendance, or timing treatments to maximize relief, all while preserving the illusion of propriety. The industry, in this sense, became a theater of control, compliance, and hidden subversion. By the early 20th century, the hysteria industry had reached a peak, both astonishing and absurd. Clinics specialized exclusively in nervous women. Instruments like early vibrators, mechanized treatments once delivered by fatigued hands, and spa towns became hubs of medical spectacle. Doctors maintained authority, patients received relief, and society continued to deny the true nature of what occurred behind closed doors. Hysteria had transformed into a sprawling cultural and medical machine, an industry that codified ignorance, exploited social fear, and yet inadvertently offered millions of women rare experiences of autonomy and sensation within a world that otherwise denied them both. In sum, the hysteria industry was more than medicine. It was commerce, theater, social control, and hidden rebellion, all wrapped in the language of science. It codified cultural fear, medical misapprehension, and societal repression while simultaneously creating spaces for unacknowledged relief. The paradox of hysteria, its ability to control, satisfy, and shock, simultaneously cemented its place as one of the most bizarre and revealing phenomena in Victorian history. By the late 19th century, hysteria had calcified into a sprawling, almost mechanical industry. Clinics, manuals, and instruments had standardized treatment, codifying ignorance and repression into daily medical routines. Physicians remained oblivious to what patients actually experienced behind closed doors. Women who attended spas, baths, or clinics endured procedures that mixed medicine with unacknowledged erotic relief. In this rigid system, Sigmund Freud entered, neither as a revolutionary nor as a critic of Victorian society, but as an astute observer who recognized the contradictions that everyone else overlooked. The medical world saw only nerves, organs, and spasms. Freud saw the mind, memory, and the hidden forces of desire that had been ignored for generations. He perceived what Victorian doctors could not, the human cost of a system blind to its own absurdity. Freud's approach departed radically from the physical interventions of his predecessors, where pelvic massage, hydrotherapy, and vibrators focused on bodily symptoms. Freud emphasized the psyche. Hysteria, he proposed, was not a disorder of the uterus, the nerves, or of suppressed nervous energy alone. It was a psychosomatic response to repressed trauma, forbidden desire, and societal constraints. Women who fainted, trembled, or experienced paralysis were not suffering from a malfunctioning organ. They were manifesting emotional and psychological conflicts through the body. In tracing these invisible threads, Freud uncovered a hidden dimension of human experience that Victorian medicine had systematically ignored, revealing that the symptoms themselves were as much a language as they were a malady. Yet Freud's own theories were constrained by the culture in which he worked. Discussion of female sexuality remained taboo, and patients often struggled to articulate their feelings, desires, or experiences. Psychoanalysis required the patient to speak, to reveal memories and conflicts that had been buried beneath layers of propriety. This method clashed with the ritualized and physical treatments of the hysteria industry, highlighting the absurdity of a system that had been convinced it could cure nervous women through massage, baths, and mechanical stimulation alone. Freud's insights exposed the fundamental weakness of the Victorian approach, its focus on the body without understanding the mind. Freud also illuminated a paradox long overlooked by Victorian physicians. The very procedures designed to enforce compliance and silence, pelvic massage, hydrotherapy, and early vibrators, delivered the exact relief they were supposedly incapable of producing. Women exhibited calmer behavior, reduced anxiety, and even improved health, not because of physiological correction, but because the treatments inadvertently addressed the tensions that were invisible to the doctor's eyes. Freud's work revealed that symptom relief was occurring without acknowledgement, proof that the human psyche, suppressed desires, and unspoken experiences had power even when denied by culture or medicine. This realization marked a dramatic rupture in the understanding of female health. Body and mind were inseparable, and ignoring one produced only partial truths. Freud's exploration also exposed the contradictions embedded in authority and control. Victorian society demanded compliance, modesty, and silence from women, while simultaneously pathologizing any deviation. The medical establishment assumed mastery over female bodies, yet the very treatments it administered inadvertently created autonomy. Women discovered ways to navigate and exploit the system, extending baths, timing appointments, or subtly guiding attendants and physicians to maximize relief. Freud's psychoanalysis illuminated these hidden acts of negotiation, revealing that the patient was not simply a passive recipient of medical intervention, but a subtle, active agent within a system designed to deny agency. Moreover, Freud's theories challenged the scientific pretensions of the hysteria industry. He demonstrated that treatment must account for unconscious motives, psychological trauma, and social conditioning. The body was not a machine, and disease could not be entirely isolated from culture. His approach encouraged an acknowledgement of desire, repression, and the interplay between social norms and human behavior, areas that Victorian medicine had consistently ignored. In doing so, Freud cracked open the rigid facade of the hysteria industry, exposing both its successes and its profound failures. Ultimately, Freud reframed hysteria not as a disease of nerves or wombs, but as a mirror reflecting societal repression, cultural assumptions, and human psychology. His work revealed that centuries of treatments had addressed symptoms without understanding causes, that relief could coexist with ignorance, and that human desire, though unspoken, remained resilient. The cracks he uncovered were as revealing as they were unsettling. Victorian medicine, with all its manuals, spas, and devices, had been both absurd and ingenious, cruel and relieving. Freud's legacy lay in exposing these contradictions, demonstrating that hysteria was never just medical, it was cultural, psychological, and undeniably human. By the early 20th century, the edifice of hysteria treatment began to show cracks that even the most dogged Victorian physicians could not ignore. Centuries of clinical ritual, from pelvic massage to hydrotherapy, had long dominated female healthcare, but new scientific approaches, psychoanalysis, and social change exposed the system's absurdity and cruelty. The once respected medical practice of inducing hysterical paroxysms through intimate, repetitive touch was increasingly scrutinized. Critics argued that the treatments were not only scientifically unsound but ethically dubious, relying on ignorance of anatomy, sexual repression, and the very real discomfort of patients. Manuals that once instructed generations of doctors to maintain strict decorum in inducing orgasms were quietly relegated to historical curiosity. The fall of the hysteria industry was neither sudden nor total, but it marked a profound cultural and medical shift. Several forces converged to dismantle the hysteria apparatus. Foremost was the rise of psychoanalysis, championed by Sigmund Freud and his contemporaries. By treating mental and emotional causes rather than assumed uterine dysfunction, psychoanalysis exposed the psychological underpinnings of symptoms previously attributed to the womb. Anxiety, repression, trauma, and societal constraint replaced the wandering uterus and nervous energy as the focus of diagnosis. In doing so, Freud and his colleagues demonstrated that female suffering had been systematically misinterpreted for centuries, not because women were inherently fragile, but because cultural and medical assumptions blinded doctors to the true sources of distress. Simultaneously, the rapid development of modern medicine introduced rigorous scientific standards. Laboratory testing, physiological measurement, and emerging gynecology provided tangible evidence of bodily function, reducing reliance on observation filtered through cultural bias. Physicians could no longer justify treatments based solely on subjective interpretations of facial flushes, spasms, or fainting. The once mighty ritual of pelvic massage was increasingly seen as archaic, unsanitary, and ethically indefensible. Vibrators, initially designed as instruments of efficiency, became associated with sexual gratification rather than therapeutic necessity. Hydrotherapy, once lauded for its calming effects, was gradually understood to offer only superficial relief without addressing underlying causes. These advancements exposed the grotesque gap between the authority of the physician and the reality of treatment. Public perception also shifted. Increasing literacy, medical journalism, and the circulation of patient accounts revealed the contradictions of Victorian hysteria care. Women recounted experiences in diaries, letters, and memoirs, describing sessions of pelvic massage or spa treatment in ways that exposed both the physical and psychological dissonance. What had been framed as clinical necessity was now read as coercive, intimate, and often humiliating. The veneer of scientific authority faltered as societal understanding of female autonomy, sexuality, and intelligence evolved. The hysteria industry, once untouchable, became a target for ridicule and reform. Newspaper articles, satirical sketches, and public discourse gradually eroded the credibility of physicians who had long been untouchable in their moral and professional authority. Yet the dismantling was uneven. Some clinics persisted into the 1,920 seconds, quietly performing procedures under euphemistic labels. Physicians trained in older methods were reluctant to abandon practices that had dominated their careers. Patients continued to seek relief, sometimes preferring the known rituals of hands, water, and vibration to newer, abstract approaches. The industry's collapse was therefore partial. It was no longer socially or scientifically dominant, but its influence lingered in cultural memory, medical education, and social expectations surrounding female behavior. Women who had endured or benefited from these treatments remembered the paradoxical mix of shame and relief. And these memories informed new generations' understanding of gender, medicine, and power. The fall of hysteria treatment illustrates a fundamental tension between culture and science. For centuries, medical authority had reinforced social control, pathologizing deviation and silencing desire. The eventual exposure of this system revealed that progress in medical understanding was inseparable from broader cultural evolution. Female autonomy, scientific scrutiny, and ethical reflection gradually displaced rituals grounded in ignorance, repression, and denial. Yet the legacy of hysteria remained, a cautionary tale of what happens when medicine enforces cultural fear rather than seeking genuine understanding. The collapse was thus both triumph and reckoning, demonstrating that the end of hysteria was not merely a medical milestone, but a profound cultural shift in how society viewed women, bodies, and desire. The story of hysteria treatment, stretching from ancient myths of wandering wombs to the industrialized use of vibrators, hydrotherapy, and pelvic massage, casts a long and intricate shadow over medical history. It is a tale not only of fear, ignorance, and authority, but also of the ways culture, gender, and medicine intersected to define human experience. What makes hysteria particularly shocking is not merely the invasive or intimate methods employed, but the assumptions underpinning them, that women were inherently fragile, irrational, and fundamentally defined by their reproductive systems. Across private consultation rooms, public bathhouses, bustling clinics, and spa facilities, medical authority operated under these beliefs, producing procedures that were simultaneously clinical, coercive, and, paradoxically, at times liberating. The Victorian obsession with nervous women codified social control under the guise of science, demonstrating how cultural fear could masquerade as medical legitimacy. Within this oppressive system, paradoxical forms of agency emerged. Diaries, letters, and patient accounts reveal women who, knowingly or unknowingly, navigated the limitations imposed upon them. By attending regular massage sessions, baths, or hydrotherapy routines, women discovered relief, physical satisfaction, and subtle means of negotiating power over their circumstances. Appointment books and clinic logs indicate repeated visits, sometimes with extended sessions or feigned distress to prolong treatment. These small, private negotiations allowed women to subvert the intended purpose of medical authority while remaining largely invisible to physicians. In a reversal of control, the very acts meant to enforce compliance became avenues for secret autonomy. Women became participants in a hidden theater of sensation, a covert dimension of personal agency embedded within structures designed to regulate and dominate. Modern scholarship has revisited hysteria through gender studies, medical ethics, and social history, revealing the disorder less as a physiological condition than as a cultural construct. Treatments such as pelvic massage, vibrators, hydrotherapy, and prescribed rest were instruments of both medical practice and social regulation. They were intended to normalize behavior, suppress deviation, and enforce social propriety, yet inadvertently acknowledged physical and psychological needs society could not openly recognize. This duality, the enforcement of conformity alongside unintended relief, illuminates the paradoxical complexity of Victorian medicine. Women were simultaneously cast as fragile beings in need of control and as capable actors, subtly resisting the systems that sought to constrain them. These contradictions highlight the broader tensions between authority and autonomy in Victorian society, demonstrating that medical frameworks often both oppressed and enabled women. The social and medical consequences of hysteria extend far beyond the Victorian period. Contemporary debates about gender bias, patient autonomy, and recognition of female sexual and psychological health are informed by this historical precedent. Hysteria demonstrates how medical authority, when filtered through cultural prejudice, can misinterpret human experience and cause harm. It warns modern practitioners of the dangers inherent in rigid assumptions, emphasizing the ethical imperative to combine clinical expertise with empathy and awareness of sociocultural context. The Victorian framework, with its intermingling of scientific posturing and social repression, serves as a stark reminder that bodies cannot be reduced to vessels of disease, divorced from identity, desire, and lived experience. The lessons of hysteria challenge us to understand human complexity in all medical practice. Ultimately, the history of hysteria is both horrifying and instructive. It chronicles the consequences of ignorance codified as authority, the resilience of individuals navigating oppressive systems, and the tension between control and autonomy. Women endured, adapted, and occasionally subverted the treatments imposed upon them, demonstrating that agency can persist even in coercive circumstances. Hysteria's narrative challenges modern readers to confront uncomfortable truths about medicine, culture, and power, highlighting the necessity of ethical, informed, and human-centered approaches to care. It is a story of fear, control, denial, paradoxical empowerment, and resilience. A reminder that the intersections of science, society, and human experience are rarely simple. Examining these historical shocks uncovers enduring truths about human desire, cultural fear, and the profound need for understanding and compassion in medicine. By combining documented evidence, personal narratives, and societal context, hysteria's legacy becomes clear. A cautionary tale of how science can be distorted by cultural assumptions and how individuals can quietly reclaim power within restrictive systems. The enduring fascination with this period arises from its paradoxes. Treatments intended for control inadvertently provided relief, and structures designed for oppression created avenues for secret autonomy. The study of hysteria compels historians, medical professionals, and society at large to reflect on the ethical, cultural, and psychological dimensions of healthcare, emphasizing that knowledge without empathy can perpetuate harm. Ultimately, hysteria's history is not merely a relic of the past, but a living reminder of the consequences when ignorance, authority, and social norms collide, and how resilience can emerge in even the most repressive circumstances.